Hello, everyone. Welcome to your lecture for today. We will start off by looking at the osteology of the pectoral girdle, as well as the muscles of the pectoral girdle. And then lastly, if time permitting, we might even move into some muscle of the arm. But let's go ahead and continue from where we left off. And I know we talked about the scapula already, but I don't think it hurts to go over it really quickly one more time. But if you look closely, you've got the scapula here, which is a relatively triangular shaped bone. It has three edges, no holes, but what you will also see on the scapula is a pretty big projection coming off of it, which is called the spine. So first, to kind of orient yourself to the scapula, it is, a relatively flat bone, and it is going to be found on the back of the thorax, just like this. But projecting outward, it's going to have this concave area that's going to be connecting to the humerus. So although oddly, a lot of people think that the wide part is going to be going out laterally. It's actually this concave part called the glenoid cavity, or otherwise known as glenoid fossa. So with that in mind, you'll be able to see that this is the lateral side over here with the lateral border, and then the medial border on the opposite side with a little bit of a rounded edge. Now, we're going to be able to use these different landmarks, the spine, the glenoid cavity, to orient ourselves. And using the spine, let's take a look at a few different depressions or fossae. So the spine of the fossa, or the spine of the scapula, you can see right here. And there's actually going to be a depression or a fossa, both above and below the spine. So name for being above or below, you have the words supra or infra. Those are going to be supra or infra spinous fossa. So supraspinous fossa above the spine, infraspinous fossa below. So if you can use the words like fossa, supra, and infra to kind of understand where you're looking and what you're trying to name, it will come at least a little bit more intuitively. So try to look for those patterns as best you can, but I'll point them out wherever we need as well. So supraspinous fossa, infraspinous fossa, but you even have one more fossa, which is actually this entire front part right here. So you can see that there is a slight curve to the scapula. This is giving it a little bit of a concave shape. That, in fact, is a fossa, which being technically on the underside of the scapula, since the scapula lies right on the back of the thorax like that, this is called the subscapular fossa. So far, a few different major landmarks, a few different major fossa, but you also have a few projections that come off the bone as well. And once again, looking at the spine, what do you see? There's something right at the end of the spine, and this is called the acromion or acromion process. So the acromion or acromion process, that is going to be able to connect to something else, which if you recognize that word, you might think it's familiar because we talked about it on the clavicle. So the clavicle has a sternal end, but also has an acromial end, which connects to the acromion. So once again, look for the patterns because instead of learning it twice, if you can remember the word once and know that they connect, then that's a good start to trying to be able to learn these structures at least a little bit more intuitively. But you do have one more projection. If you look closely, we're on the back with the spine. That's where you can find the acromion, but on the front with the subscapular fossa, you have another process that's not on the spine. So acromion is back here connecting to the clavicle. This is actually something else called the coracoid process. So coracoid process, coracoid, and I'm saying it slowly because there will be other things that sound familiar, but coracoid process, that's going to be projecting anteriorly off of the scapula. Now, one more thing that you'll be able to see kind of at the top of the scapula, and using the words like to describe that, suprascapular, or sometimes just scapular, but right up here, you have this little kind of divot. This is called the suprascapular notch. And you can see the suprascapular notch here as well, which is going to be right at the top of the scapula. Now, speaking of the suprascapular notch, it's actually going to help with forming another structure, which if you look closely, you have the suprascapular notch with another thing right above it, which is called the superior transverse ligament, or more, intuitively, the suprascapular ligament. So together with the ligament and the notch, you can see that it starts to form a hole, and we have a word that describes holes, which instead of fossa, instead of process, instead of spine, this is called a foramen. So what we call this, like kind of on the top of the suprascapular notch, is the suprascapular foramen. Now, the suprascapular foramen, it's going to be a good landmark to look for because there are two small things that you're going to want to try and look related to it. So if you kind of like look at that, or if you try to find that on the cadaver, there's two things that we're going to try to look for around it. And one of them will go through, but one of them will go above. So suprascapular nerve is going to travel through the suprascapular notch, or rather suprascapular foramen, and then above the suprascapular foramen, right above that superior transverse ligament, that's the suprascapular artery. So there will be two things that you want to look for, like right around this thing, but also to differentiate them, look for the one that goes through, which is the nerve, and then look for the one that goes above the notch, which is the artery and vein. Now, one more notch that we'll be able to see in addition to suprascapular is something called the spinoglenoid notch. So this one actually isn't even that visible on this picture, but it's still, you'll be able to see it. But spinoglenoid, that's going to be right along like the projection of the spine, right above the glenoid cavity or glenoid fossa. So it's going to be right kind of like under the hooking region of the acromion and the spine as it projects further off the scapula. So maybe you can see a little bit better over here. This is where you'll find the spinoglenoid notch. So the spinoglenoid notch is also something that's very helpful to look for because there will be things that travel along there as well, which will be like the continuation of the suprascapular nerve, and then it will go further down into like the infraspinatus muscle as it travels. So looking for these notches can be helpful for looking for certain nerves and blood vessels, which is what those landmarks are kind of helpful for. But just try to keep these in mind and also ask yourself, is there something that we're looking for while we're here? Now, moving on to the arm bone itself, we have the humerus. So you actually have a singular bone that's going to be found in your arm. And just to remind ourselves, we're talking about arm as in elbow to shoulder. So this right here is where you'll find the humerus or your arm. And to start off with, let's talk about the proximal side as we look at the shoulder. So if you look at the head or the humerus, so I guess the first thing that you want to ask is, how did we know that this was the humerus? So number one, I mean, it's a long bone. It's something that's going to be longer than it is wide, and it extends off of the body. So it's one of the long bones. But this is actually one of the unique long bones, which is going to have a very rounded head at the proximal side. But there's actually going to be two bones that are going to be like this, the humerus, but also your thigh bone, the femur. So the humerus and the femur both have a ball end, but in order for you to know the humerus, I mean, just look at the head versus or the head of the humerus versus the femur, and you'll actually see that there's a large difference in their necks. As in, like the femur is going to have a long neck that allows it to extend away from like the shaft of the bone, but the humerus has the head basically directly on the end. So I mean, this is kind of like a really short neck. So imagine someone like this, and that's kind of what the humerus is like. So the humerus is going to have a really short neck. And in fact, we have two names for like the neck. One that's going to be called the anatomical neck, which is where the head of the humerus, that round part, literally, like physically connects to the bone. But then down here, right along like kind of like the bottom of the head, this is what we call the surgical neck. And the surgical neck is where bones will often break more, or that's where surgeries could also be related as well. But it's not just the head. I mean, the head helps you to know that this is the humerus, but there's other things here too. And to start off with, there's a couple of new words to introduce. So Number one, we have tubercle. And while we're at it, number two, we have the word tuberosity. So those two are actually pretty similar to each other. They're going to be these bumpy projections that kind of come off the bone, but tubercles will usually be a little bit more rounded, while tuberosities will be a lot more rough. So tubercles, I mean, both of them are going to be kind of helping for like attachments, but tuberosities especially are a lot rougher usually to allow for a strong attachment of a tendon or ligament. So looking at the proximal end of the humerus, though, you can see that you have these two different projections, one on the front, one on the side. So on the anterior side, you'll see this little bump. That is a tubercle. And then on the lateral side, you'll see a bigger bump, which is also a tubercle. So name for their sizes, the anterior tubercle is called the lesser tubercle, and then the bigger tubercle is called the greater tubercle. But then in between the tubercles, you'll also see another landmark, which is a groove in between them. And one more word to kind of learn here, we have what's called a sulcus. So the sulcus, if you learned anything about the brain, you might know that a sulcus is like a crack between like, well, the gyri of the brain, but this is a sulcus between the tubercles of the humerus. So lesser and greater tubercle, and right in between them, the word for between is inter. This is the intertubercular sulcus. Now, as you're looking at those tubercles, you'll see that you'll have these faint, kind of like gradual ridges that are traveling down from them. Those are called the crests of the lesser and greater tubercle, respectively. Now, on the side of the humerus, there's going to be a point of attachment for a certain muscle. And if you know anything about, like, the muscles of the shoulder, there's this big muscle that kind of rests right on the shoulder cap. That's called the deltoid. And if you look closely, although it's going to be a little bit hard, there's this rough part right on the lateral side of the humerus. That's called the deltoid tuberosity. So it's usually somewhat in line with the anterior portion of the greater tubercle. So if you have a greater tubercle over here, right down here, this is where you're going to find the deltoid tuberosity. I know this lighting isn't really doing it justice, but it's a rough part right over here. But lastly, there's one more thing that's right next to the deltoid tuberosity, directly behind it, in fact. And once again, it's going to be a little bit hard to tell, but here's the deltoid tuberosity. Then do you see how you have this ridge that's traveling a little bit in a diagonal path and spiraling around the humerus? This is where a certain nerve is going to be traveling, which is called the radial nerve. And name for this is called the radial groove or radial line. So we'll talk more about the humerus later when we get to the distal end, but let's go ahead and keep on going and talk a little bit more about the shoulder. So once again, though, here's the humerus, here's the scapula, and even the clavicle, but to talk a little bit about the head of the humerus and its anatomical neck, like I was briefly saying, this is where you could have more fractures or more breakages, and this is where like the surgical neck would be a lot more prevalent than the anatomical neck. So if something breaks, it's not usually at the anatomical neck, it's at the surgical neck. Now, for coordination between each other, there is actually a little bit of specificity to this, as in like it's not just like, perpendicular angles and one just lying right directly next to each other. The human body actually does have kind of like a different resting position due to, tissues, but also comfort and lack of flexibility. But there's a couple of angles to talk about, as in the first of which is called the angle of inclination. So the angle of inclination is actually an angle where the humerus ever so slightly kind of like goes outward from like the shoulder joint. And this is at about a 135-degree angle from the head of the humerus going downward. So this would be kind of like where the humerus is right at the side. And if you were to look at the humerus in this way, you can see that you have the head of the humerus and then the 135-degree angle. So it's not perpendicular, it's not 90 degrees, it's not like going straight down, but the head of the humerus actually kind of like leans, or not leans, but is projecting inward a little bit more. And when it does that, that allows the head of the humerus to fit a lot better with the glenoid cavity, but that also causes the humerus to play out just a little bit. So you want, like, a larger kind of contact with the glenoid cavity. That's going to give you a lot more range of motion, but this is just what's going to happen. I mean, you're going to have the humerus just a little bit outward in this case. And in a similar manner, to once again kind of have like a comfortable position, but also an anatomical position, there is an angle of what's called retroversion. So in this case, the head is rotated about 30 degrees and specifically posteriorly. So when you have the medial and lateral epicondyles kind of like lined up so that the elbow is going to be completely anteriorly projecting, this would be the correct angle of retroversion. Now, to talk about these joints, there are some like specifics regarding like how these are connected, how they're supported. So let's go ahead and start by talking about these. And actually, one of the big things about talking about joints is actually how do they move? So when we talk about the whole shoulder joint, there's actually a little bit to it besides just, humerus and scapula, they just humerus like moves around, but there's actually a little bit more than just that, which is what we call the scapulohumeral rhythm. So scapulohumeral rhythm is kind of like a combination of the movement of the scapula and the humerus to allow for an effective shoulder or a more effective shoulder joint. So effectively, the scapula and the humerus move together when you lift your arms upwards to abduct them, but they do it in a certain ratio, which is about a 1-to-2 ratio for the scapula to humerus. So in this case, like for every 10 degrees the humerus moves, the scapula will move 5. As in, like, for whatever the scapula moves, the humerus will move twice as much. So if you were to, move the arm in a 180 degrees, then the scapula will move upwards and rotate 60 degrees of that 180, and then the other 120 will be due to the movement of the humerus. Now, there is one thing to note, though, which is that in the initial 30 degrees of movement, that's generally just humerus. So when you have a large range of motion with the shoulder, you use the humerus for sure. I mean, that's definitely pretty self-explanatory, but you also use your shoulder as in your scapula. So the scapulohumeral rhythm is in a 1-to-2 ratio between the scapula and the humerus. Now, to take a look at some joints, let's go ahead and see how a lot of these pectoral girdle bones are going to be connected. And to start off with, we have what's called the sternoclavicular joint. So sternoclavicular joint, I mean, what does that tell you? It's going to be between sternum and clavicle, and specifically the sternal end of the clavicle and then the manubrium. So the sternoclavicular joint, you can see right here where the clavicle meets with the manubrium, and this is going to be a somewhat mobile joint, but it's not going to be like the most mobile. It's going to be biaxial, and it's considered kind of like a saddle joint, but saddle joints usually only move like, in one direction. So it is somewhat planar. So it moves and it doesn't move a whole lot, but as you move your shoulder, this joint is going to be required to like be at least a little bit flexible. So in order for your sternoclavicular joint to stay together, we have a few different ligaments. So luckily, some of these are, or most of these are actually pretty, not too bad. But on the front and the back, you have a sternoclavicular ligament. So on the anterior side and the posterior side, you have a sternoclavicular ligament. So that's just helping to connect something on the front and the back. But then if you look closely between the clavicles, you also have this ligament kind of connecting them right in the middle. So you have ligaments on the front and the back, and then you have a ligament between the clavicles, kind of keeping them well supported as well. But then you also have the costoclavicular ligament as well. So, I mean, clavicle to sternum, and then clavicle to clavicle, those make sense. But you also have one that's a little bit aside, which is called costoclavicular. And if you remember the word costo or costal, like in intercostal, this is referring to the ribs. So costoclavicular ligament, that's going to be right over here. And you can see that connecting between the clavicle and the rib. So as usual, this is going to be or surrounded by a joint capsule. It's hopefully going to be pretty strong, otherwise your shoulder is going to fall off. But it does have a blood supply and a nerve supply, which is from the internal thoracic and suprascapular arteries. So remember, suprascapular means like along the top of the scapula. That's right along this area. But then also internal thoracic is an artery that's going to be running right along the back of the sternum. Now, we'll be able to see that a little bit more when we get into the thorax, but there's also a couple of nerves, which nerve to the subclavius, which is a muscle under the subclavius or under the clavicle, and then also the medial supraclavicular nerve as well. So notice a lot of supraclavicular because, or supraclavicular or suprascapular because that's kind of like where we are. But then subclavius, that's going to be going to a muscle underneath the clavicle too. Now, our next joint is called the acromioclavicular joint. And once again, try to think about that. Clavicular, clavicle, but acromio, that's the acromion process. So between the acromion process and the acromial end of the clavicle, this is where you're going to have, well, another joint. So once again, this is a synovial joint, being that it's going to be pretty mobile. I mean, when you move your shoulder, you're definitely moving this part as well. And this is going to be triaxial, being that it's going to be a little bit more mobile and being like not necessarily a saddle joint anymore. This is a planar joint. So this is going to allow some sliding, kind of like in different angles, and it's going to give a little bit of range of motion to, well, I guess your scapula and your clavicle, not necessarily your glenohumeral joint. So being a synovial joint, it's surrounded by a joint capsule, but there's also quite a lot of like little ligaments surrounding them too. So to start off with, acromioclavicular joint. So acromioclavicular, that's going to be between the acromion and the clavicle. So acromioclavicular is the one that you usually think, or that you think of first, connecting directly from acromion to clavicle, which you can see right here. But then to keep it all like together supported as well, there's also going to be coracoacromial ligament. So coraco, do you remember the coracoid process? And then the acromion here, there's going to be a ligament here, which actually forms like the roof of this shoulder joint where a lot of stuff will kind of pass through. But then lastly, you have two more that connect from coracoid to the clavicle. And there's actually two parts to this. So do you remember how you had like a couple of a couple of rough regions or landmarks on the bottom of the clavicle, the trapezoid line as well as the conoid process? That's where you're going to find these two, the trapezoid ligament and the conoid ligament. So trapezoid ligament and conoid ligament. Those are going to be kind of like or trapezoid ligament and conoid ligament. Those are going to be on the bottom of, or connected to the bottom of the clavicle from the coracoid process. So your acromioclavicular joint, it's similarly going to have blood vessels and nerves. And in this case, it's the suprascapular nerve and the thoracoacromial, or sorry, suprascapular artery, which is right along that area. and then thoracoacromial artery as well. And then some nerves that we'll be learning soon, suprascapular nerve, that will like be right along that area too. And then the lateral pectoral nerve and even the axillary nerve will be here as well. So axillary means armpits, and then lateral pectoral nerve, that's going to be a nerve that's going to your pectoralis major and minor. Now there's another kind of like weird joint here, which is between like the clavicle and then the thorax, which technically isn't really like, bones connecting, as like they're not really connecting directly. But what you will have is a lot of motions between the two, which will be coordinated along the thorax using the scapula. So as we'll see, the scapula is going to be in charge of like the total movement of the shoulder a lot, either upwards, downwards, side to side, and so on. So let's go ahead and talk about that. So the scapula, if you look closely, well, let me just move this real quick. The scapula is going to be found along the back of the thorax, but also along the side. But there's going to be a few different types of movement that can occur using the scapula. So first of all, an interesting one is something called tilt. So tilt is where like the scapula will be able to move along the sagittal plane, either forward or back along like this plane like this. And a good way to like look at this is to look at like that coracoid process. If the coracoid process goes downwards, that means that it's going to point down or like tilt downward or anteriorly. And what that's also going to mean that it's, well, tilting anteriorly, but also becoming a little bit more horizontal. While posterior tilt is going to be pointing the coracoid process upwards, along with the subscapular fossa upwards as well. So these are going to be different types of tilt, which is going to help with allowing the shoulder to kind of like wrap around a little bit more. But along with the tilt, you're also going to have a couple more or a few more movements. So elevation and depression are pretty self-explanatory, luckily. It's the ones that are going up and down. So elevation is up, depression is down, and you can imagine this like lifting your whole shoulder when you shrug your shoulders, or letting it down or pulling it down through depression. But then we have another type of rotation, which is upward and downward rotation, which is not technically referring to, like the whole angle along the sagittal plane, but this is going to be moving mostly this bottom part. So remember, the acromion is kind of like connected here and anchored at the clavicle. So when you have like these kind of like tilting or rotation rather of the scapula, imagine this inferior angle either going upwards for upward rotation or downwards for downward rotation. So largely, a good thing to also keep in mind is that it's not just this inferior angle, but this is also going to be moving the glenoid fossa or the glenoid cavity. So dependent on that, it could cause the glenoid cavity to be facing upward more or downward more. So that's probably the better way to like consider like the rotation. What happens to the glenoid cavity? Does the glenoid cavity go up or down for upward or downward rotation? Now, lastly, an interesting one. The scapula can also move along the thorax, kind of like sliding around it. And this is in an anterior and posterior direction, which is protraction or abduction, or retraction or adduction. So protraction doesn't make as much sense with abduction, but it does. I mean, like, it does go to the sides a bit, but mostly, if anything, protraction is when you bring your shoulders forward. So imagine bringing your shoulders forward, and if you want to, try to like do a pushing kind of like motion. This would be protraction, and you should feel your shoulder blade coming along the side of your thorax. And then opposite to that, you have retraction, which is bringing your shoulder blades back and closer together. And that would be adduction of the shoulder blades. Now, one more big joint that we'll see here is the glenohumeral joint. And the glenohumeral joint is the big one because this is where the humerus and the glenoid cavity meet. So this is going to be the most mobile. This is the one that's going to be a ball and socket joint with many angles of movement. But we have some specific movements that we're going to be describing here. And just to remember, we are moving the arm. So when we talk about like movements of the glenohumeral joint, we're talking about movements of what's happening specifically to the humerus. So moving the forearm is technically different, but it obviously moves with it to some extent because it's attached. But we are talking about how is this going to move? As like, how is the humerus going to move? So these movements are described along their different planes. So along the sagittal plane, that's where you have flexion or flexion and extension. So flexion and extension will be where you bring your shoulder upwards like this to decrease the angle of the shoulder, or extension to bring your arm backwards like this. So shoulder flexion versus shoulder extension, that's going to be moving the humerus to increase or decrease the angle. While abduction and adduction, abduction is bringing your arms outwards like this, and then adduction is bringing them back down. So I know I've been throwing these words around quite a bit already, but abduction with a B, like if you think about any type of abduction, but in this case, I like to think of alien abductions, it's lifting your arms up and away. So anything being lifted up and away is going to be abduction. And then adduction with two D's, as in D as in dog, brings your arms downwards to add your arms kind of like back to everything else in the body. And then you also have a couple of different types of rotation or movement along the transverse plane. So first of all, internal and external or lateral and medial rotation. For that, imagine your arm kind of like this, and then bring your arm either outward or inward. So in this case, you're definitely kind of like moving your forearm, but what you're actually moving to do that is you're twisting or rotating your humerus. So internal and external rotation, that's going to be rotating the humerus either medially or laterally. And then horizontal abduction and adduction. If you imagine your arms out like this, though, this is going to be where you abduct or adduct horizontally. So it's still kind of going towards or away from the midline, but you have abduction and adduction respectively. So the glenohumeral joint, this is going to have some ligaments as well, but these ligaments can be a little bit more blended together to some extent, but they are luckily relatively simply named. So the first three that we have here, well, number one, you have the joint capsule. This kind of covers everything, but number two, on the front of the glenohumeral joint, this is where you're going to have a couple of glenohumeral ligaments. So, I mean, you have 1, 2, and 3, one at the top, one in the middle, and one at the bottom, which is called superior glenohumeral ligament, middle glenohumeral ligament, and inferior glenohumeral ligament. So these three ligaments are going to be helping to support the glenohumeral joint from the front, but along with that, you'll also have the coracohumeral ligament. So although it's kind of covered a bit by this tendon over here, you can see a little bit of that poking out, which is called the coracohumeral ligament. So this is going to be connecting from the coracoid over to the greater tubercle of the humerus. So it kind of, once again, blends with other ligaments or tendons, but you can see a little bit of it poking out over here right above the superior glenohumeral ligament. And then you also have the transverse humeral ligament, which isn't technically like supporting like the glenohumeral joint too much. But if you look up here, you can see that there's a ligament that's traveling right across the intertubercular sulcus. This is called the transverse humeral ligament, and that's where you're going to see a certain muscle tendon traveling underneath. Now, lastly, a few things regarding like joints is that you also may see these things called bursae or bursa. These bursae are going to be basically the kind of like sacs of synovial fluid, which is going to allow for support, but also a lot more lubrication of these joints, especially of joints that like are a lot more mobile, like the knee, the hip, as well as the shoulder, as we'll see. So luckily, once again, look at the names and you can kind of tell where they're going to be. Subacromial, so underneath the acromion, subacromial joint, or bursa rather. Subdeltoid, subdeltoid bursa is going to be underneath the deltoid. And then subscapular bursa isn't really shown very well on this, but subscapular bursa will be kind of like near the back. So these bursae are going to be underneath like some of these, or underneath and between some of these ligaments to help with allowing for a little bit more lubrication and support. So I think that should be about, oh wait, one more thing. So if you look closely, we have the coracoacromial arch and the subacromial space. This is kind of what I was talking about regarding that a coracoacromial ligament. So the coracoacromial ligament, you'll be able to see going across here. And then that's going to be this roof or arch. And that's going to be forming this little space right here underneath it. So this is going to be the coracoacromial arch formed by the coracoacromial ligament. And then this space right here between the glenohumeral ligaments and this ligament, this is going to be a space where stuff like the supraspinatus and other things are going to be located. So this is going to be just kind of like some anatomy of the glenohumeral joint, which is allowing it to, allowing other things to also travel through here. So I think with that said, that should be it for this lecture. So let's go ahead and talk about some muscles, and then we'll go ahead and finish up. Well, actually, I think I'll make another video for that. So at this time, that's about it for the pectoral girdle, but I'll make another video regarding the muscles of the pectoral girdle as well. So looking forward to that, but thanks for listening. Good luck with your studying, and I'll see you all next time.